today exactly, and then under the theme of caring for people and protecting the planet. So as many of us may know, chronic kidney disease worldwide is it's a very big health challenge with an estimated patients more than 850 million, which is 2 times higher than the diabetes patient and 20 times higher than the HIV patient. And each year, 5 to 10 million people are estimated to need one of the renal replacement therapy, either dialysis or kidney transplants. So this is a growing global initiative that's to expand kidney transplantation program worldwide, including low and middle income countries such as Rwanda. So in Africa, it's estimated to have around 35 kidney transplant program in place. And current evidence shows that establishing this kind of program can be both sustainable and cost effective. So, but why do we emphasize on kidney transplantation? So because transplants shows survival and quality improvements comparing to long-term chronic dialysis. So it has been increasingly recognized as part of also green nephrology, as the theme of this year is protecting the planet, as a transplantation can sustainably reduce the environmental footprint associated with chronic dialysis. So in today's discussion, we will mainly focus on kidney transplantation and donor safety, with a special segment on pediatric kidney transplantation. And as we know, kidney transplantation, yes, remains the optimal treatment for end-stage kidney disease. So ensuring safety of kidney donors is also a fundamental pillar for any transplant program. Careful donor evaluation, ethical processes, long-term follow-up are very essential to protect donors, which are our heroes, while expanding access to this life-saving therapy. So we'll also highlight, as I said, kidney transplantation in pediatrics, which is a transformative intervention that allows children with kidney failure to grow, develop, and have a healthy lives in the future. So, and especially we also emphasize on Rwanda achievement as transplant services in the country is ongoing, with a very big commitment from the country to strengthen kidney care currently. So thank you all for joining. I'm looking forward to insightful discussion ahead, and we would like this webinar to be very interactive. So please share your comments, your questions in the chat, and feel free at the end of any in each presentation to raise your hand for participation. So in total, we'll have three presentations. The first presenter is going to be Dr. Gloria Shumbusho, who is a consultant transplantation program at King Faisal Kigali. She also serves as the coordinator of internal medicine postgraduate program at Africa Health Sciences University. So she's very involved in nephrology fellowship program and medical education in general. And her primary area of interests includes clinical nephrology, kidney transplant, research, and aim at improving patient care. So Dr. Gloria, this is your flow. I'm going to share the presentation.
Thank you, Dr. Darlene, for the nice introduction. I think you talked about everything. So, yeah, thank you. Good evening, everyone, and good morning for those who are on the other side of the globe. I'm Dr. Gloria Shumbusho, and I'm going to talk about kidney transplantation as a sustainable solution for kidney failure in low resource settings. And I will focus on recipient because my colleague will talk about the donor. Okay, so I'm trying to change the slide. Okay. My goals for this presentation is to remind everyone about the burden of chronic kidney disease worldwide. And so we'll say, okay. Darlene, am I the one who changed the slide, or you are changing the slide for me? Because
I'm not,
there,
but I can do it for you.
'cause I'm trying to change, but I don't know. Maybe you can change them for me, please.
Yes, no.
Thank you. So next slide. So these are the goals of this presentation. I want to again remind everyone the awareness about the burden of chronic kidney disease, and we try to answer the frequently asked question about I know most of us about transplant, there's not available what we are currently at King Faisal Hospital in terms of kidney transplantation. I don't have any conflict interests to declare, and I think, okay, I don't know. Next slide, please. Thank you. So as Dr. Darlene was saying, chronic kidney disease is a public health concern, and the 7th World Health Assembly recognized CKD and kidney health as a global priority, and there's a call to all countries to emphasize on kidney care as a first of all as prevention for kidney disease, and again in management early stage of CKD by offering patients who are diagnosed with chronic kidney disease, offering them a universal health coverage. Darlene, I can't proceed with this. I don't know what to do. I was confused. Or maybe I should share my screen. I don't know.
I'm giving you the access to reshare. Then see. I use that one. The presentation. I apologize for the technical inconvenience, but we are coming back very soon. Sorry again. Uh, Sorry again. As maybe time is running to just keep up on the schedule, I'm going to ask Dr. Hayden Elizabeth to be our presenter now while we are figuring it out the for the presentation for Dr. Gloria.
Of
So,
course.
so Dr. Hedren is a clinician researcher within the Division of Nephrology at University of British Columbia. She's a transplant nephrologist and a renal obstetric specialist at St. Paul Hospital. And her research focuses on pregnancy in transplant recipient and recurrent GN after renal transplant. And she's also very keen in improving equitable and accessible transplant care to patients in British Columbia, Canada. So the floor is yours, Elizabeth.
Wonderful. Would you like me to share my slides?
Yes, go ahead, please.
Okay, perfect. Great. Now, can you see, do you see my slides or do you see the background? Do you see the right screen?
It's the presenter screen, Liz.
We can.
There we go. Is that better now?
Yes. Yes.
Great. So thank you, everybody. I'll be chatting a little bit about our living kidney donation program in BC. And we recently had one of our kidney transplant recipients design this pin here in honor of his living kidney donor. So they say freely given and freely received. And I think that really summarizes how we feel about living kidney donation in BC. I have some non-relevant conflict of interest that will not come up today. So we'll be reviewing the risks of living kidney donation, reviewing the evaluation process in BC for a potential living kidney donor, and then review the follow-up requirements after nephrectomy. So as many have mentioned today, we know that kidney transplant is the treatment of choice for most patients with end-stage kidney disease, as it offers survival and quality of life improvement, as well as cost savings compared with dialysis. And that's also a very important thing to consider. And so we know that living donor kidney transplant offered the best graft survival and patient survival compared with deceased donor kidney transplants. And so wherever possible, living kidney donation is the preferred type of donation. Living kidney donors are healthy individuals who voluntarily undergo risks to undergo a donor nephrectomy. And so assessment of this these risks involves a multidisciplinary team, including medical, surgical, and psychosocial evaluations. And all living kidney donor programs should have all of these teams sort of working together to both evaluate the risk and discuss the risk with the patient. In Canada, about 2/3 of our kidney donors are deceased and 1/3 are living. And overall, over time, our living kidney donation rates are staying pretty constant. But it is something that we're always looking to improve by removing disincentives that may exist for living kidney donation. And so things that we have done is looking at taking away financial disincentives and looking so that people can get paid time off of work and that people can basically not have to pay such a big cost in order to become a living kidney donor. So when we think about living kidney donation candidacy, our primary concern as the donor nephrologist is to evaluate the impact on the kidney donor's health. We also want to assess the donor motivation and protection from coercion to make sure there's not an external source of somebody that is putting either pressure or financial coercion on the patient in order to donate. We assess their medical, surgical, and psychosocial risk, and then we balance donor autonomy with the overall program's tolerance for risk. And so we want to respect the donor's autonomy while also not putting them in a position that they could put themselves at harm. When we think about the risk to the patient, the main risk that we see 100% of the time will be a drop in kidney function. And so people are going from 100% kidney function to 50% overnight. And then we do find that there's renal accommodation in the remaining kidney. And so we expect that the GFR will end up at about 70% of the pre-donation eGFR. And overall, when we look at large numbers of kidney donors in the US, it's our best data for this. There's about a 0.3% chance of end-stage renal disease at 15 years post-donation. So the overall rate of end-stage kidney disease is very, very low and is in fact lower than the general population, but is slightly higher than healthy non-donors. So there is definitely an increased risk, about double, of developing end-stage kidney disease compared with a very healthy person that does not donate their kidney. But overall, the absolute risk is very, very low. There's also surgical risk. And so we think about mortality is obviously the most important surgical risk. And this is, we see that as less than 1 in 10,000 kidney donors will die. And then GI bleeding and respiratory complications do exist. They're probably closer to about 1%, but overall are very rare. Long-term risks, there are higher risks of hypertension. There's no higher risk of hypertension, and this has been confirmed in recent studies using prospectively enrolled living kidney donors and controls with following their blood pressure serially over 10 years. So there's no difference in the change in blood pressure in kidney donors compared with controls, and also no difference in the rates of proteinuria post-donation. And so this is very, very high level prospective data that we have supporting this. There may be an increased risk of gout, but for most patients, this is pretty not necessarily a significant clinical risk. And in women, we do worry about pregnancy complications. And so there is a slightly increased risk of preeclampsia. And so female kidney donors may choose to donate after pregnancies. And sometimes if we know that somebody is planning a pregnancy in the next 1 to 2 years, we may opt to suggest that they have their pregnancy first and then donate after. That being said, we follow living kidney donors in our pregnancy clinic at St. Paul's Hospital where I work, and we rarely see significant pregnancy complications. And so this is probably just slightly higher than our baseline population risk of preeclampsia. And finally, there's psychosocial risk. So if somebody donates under coercion or without thinking about the donation enough, there is the possibility of donor regret. And so we do a very complex psychosocial evaluation to ensure that the rate of donor regret is rare. And then we think about the direct and the indirect costs in terms of time off work, travel, and accommodation, and then indirect, like an inability to get life or disability insurance after the donation. And so we work with the Kidney Foundation of Canada to run a reimbursement program for any donor expenses. And so if you have to travel from one part of the country to another in order to donate, I know Rwanda is a very small country, Canada is a very large country, and it can cost thousands of dollars, to travel from one part of Canada to another if your donor lives in another area. So we have a program that reimburses patients for all of those expenses if they're not covered through their work. When we're evaluating donors, the first thing we do is have a screening medical social health questionnaire where we ask about questions about high blood pressure, diabetes, any known medical problems. We then do a series of baseline testing, ECG, X-ray, ultrasound. We ensure patients are up to date on age-appropriate cancer screening, and we check their blood pressure and do blood and urine studies. If those all look appropriate, we then bring donors in for an in-person evaluation with the surgeon, the nephrologist, and the social worker. And we do a CT scan to assess for donor anatomy. We also do a donor renogram, which tells us the split of the kidney function between the two kidneys, and also gives us a sense if there's any sort of urinary obstruction, or it also gives us a very accurate GFR. Many programs will not do the renogram standard. They'll only do it if there's a size differential on the CT scan. So that's not necessarily mandatory, but we do it by default in all of our donors. We then review as a team, and anybody who flags an issue can discuss what their issue is, and then patients will be approved. So about 10% of our donors that start this process end up being approved. So for every 10 donors that comes forward, probably only about 1 to 2 will actually make it through this whole process where they complete the questionnaire, go through the testing, come for the appointment, and then are actually approved. So we do need a lot of donors to register in order to approve 1 to 2 donors. After kidney donation, we follow up with them with labs and a surgical appointment at 2 weeks to just evaluate any surgical healing issues or complications. And then we do a telehealth visit with the nephrologist at 8 weeks to ensure that the kidney function and the blood pressure are normal and that things are normal. After that, all the remaining follow-up is done through the patient's primary care team. So at 6 months and 12 months, and then annually, we ask for kidney function and diabetes tests to be done, as well as a blood pressure check. If any issues are identified, we run a complex donor clinic. And so if you're losing GFR faster than we would expect, you develop challenging to control hypertension or diabetes, we refer you straight to see a nephrologist, no questions asked, and someone who has experience with living kidney donation. And so we want to be using those CKD therapies early on, like SGLT2 inhibitors and other new treatments, to slow the rate of progression of kidney disease if there is any concerning features coming up. We also recommend that patients avoid nonsteroidal anti-inflammatories, dietary changes, that they avoid dehydration. And we exercise about 150 minutes per week, and they see their family doctor. So we basically want people to maintain that same healthy lifestyle they were having coming into transplant. So to summarize, this is how we run our program in Canada. So we start with sort of the least invasive testing, which is just the medical questionnaire. And then we move patients through progressively more invasive testing until we get to the final stage where they go on to donate. And once with this strategy, we find that we have very low rates of donor regret, donor coercion, and our outcomes are generally very, very good in terms of long-term kidney function. We also prioritize previous living kidney donors on our deceased donor waiting list. And so if all of this fails and you do end up having end-stage kidney disease, we will give you top of the list priority, including preemptive listing for a deceased donor transplant to try to acknowledge the gift that you have given. And so that's something else that I think is very important as sort of a backup strategy for living kidney donors to have it there. And so this is just sort of meant to be a brief introduction to what we do. And so happy to answer questions at the end about how our program works in Canada and any other thoughts that people have.
Thank you so much, Dr. Hedrick. It was very nice, very concise, and very clear. I have one question for you. So do you have any strategy for tracking those donors for the annual checkup? I'm asking this mainly for those young donors who are otherwise healthy and might neglect sometimes those checkup. Do you have any strategy to track them down? Thanks.
Yeah, our biggest strategy is really screening people in advance to be the type of people that are already getting routine follow-up with their primary care doctors. And so we will actually call primary care doctors of very younger patients. In Canada, many people will see their primary care doctor before donation just for routine checkups. So we'll take that into consideration. Are you already seeing a primary care doctor, perhaps for a contraception prescription or for unrelated sort of issues. But we don't have a way of tracking because there's so many kidney donors. We have thousands of kidney donors across BC. We can't track all of their blood to make sure they're doing it every year. So we just really rely on having reliable people. And then Dr. Habib Ramana is asking, in Canada, how are donor organs sourced and allocated? So we have, through our deceased donation process, we have provincial organ procurement organizations that are in contact with intensive care units across the province. And so the intensive care unit will there's a law that the intensive care unit has to contact the OPO whenever they have a potential patient that they're about to withdraw life support on. And then if they are eligible for donation based on clinical factors before they withdraw life support, we have a team of organ donation specialists from the OPO that will travel to that ICU and they will talk to the family before life support is withdrawn. So the ICU identifies the patient and then the transplant organization goes in to consent the family for donation, and then they will let the transplant centers know that they have a potential donor and make sure that there's people that want to take those kidneys that they're about to procure.
Thank you, Dr. Elizabeth. We'll keep checking on questions and maybe come back up later. So let's welcome back Dr. Gloria, who will represent again her presentation.
Thank you, Darlene. I'm sorry for these technical issues. So quickly starting, we're saying that CKD is a public health concern. In Rwanda, we have almost 12% of patients with CKD at different stages, and probably 100 per million people with end-stage kidney disease. And this is a heavy financial burden, especially for as a low-income country. And again, 94% of those patients, they can't afford kidney replacement therapy. So the KDIGO recommends the approach of chronic kidney disease by starting by preventive measures, lifestyle modification, and risk modification. And if these fail, delay the progression of CKD, focusing on albuminuria, which is an independent predictor of kidney failure. And there are a lot of drugs that have been in trials and that are approved to delay the progression of proteinuric CKD, including RAS blockades and SGLT2 inhibitors, which are available even here, and mineralocorticoid receptor agonist and GLP-1 receptor agonist. So the management of CKD, I think we should focus on probably delaying the progression, as kidney replacement therapy will be more expensive in our region. So delaying the progression will save more lives and more burden to the countries. So on the left side, we have risk factors of kidney failure, or like disease that conditions that may predispose CKD patient to progress to kidney failure that we should focus on. And now, because we are focusing on kidney replacement therapy, the modalities that are available is kidney transplantation and dialysis and conservative kidney care. So for comparing dialysis and kidney transplant, most of studies favors kidney transplant over dialysis, and mainly because the survival rate with dialysis is shorter, like 5 years survival rate with dialysis, only 40%, while it goes above 90% with kidney transplant. And kidney transplant is associated with reduction in mortality, in cardiovascular events, and even improved quality of life. And the cost, as it was said, the cost and the treatment burden of dialysis outweighs the cost of kidney transplant over many years. And again, dialysis has a negative impact on the environment. So I'm going to give a brief introduction on what is kidney transplant, and then I'll share what we are doing here at King Faisal Hospital. So every organ donation is a gift of life for someone in need, and kidney transplant is a treatment of choice. Only one kidney is needed for patient survival, and the donor can survive with one kidney as well. And preemptive transplantation is a preferred treatment option, meaning transplant before dialysis. So transplanted kidney, as was said, we can get them from a living donor or a deceased donor. And as said in the previous presentation, living donor safety is paramount when deciding on donation. So we should focus on living donor safety, and say the success rate is now above 95% in the first year, and the graft can survive for 15 to 20 years and even above 20 years. So usually the kidney is implanted in the iliac fossa, either the right or the left. And most of patients usually ask if the native kidney will be removed. They are not removed unless there is indication to remove them, like if they are of large size and polycystic and occupying space for the transplant. So kidney is the most organ transplanted worldwide. Unfortunately, in Africa, the transplant program are limited, and the access is limited, only available mostly in Northern or South Africa, and most of patients are travel to India. Most of African country, the patients travel to India to get a kidney transplant. So the challenge is the limited access to the transplant program, the shortage of donated kidney, which lead to long waiting lists in transplant program if available, and also organ trafficking and transplant commercialism and transplant tourism. So this is a brief history of kidney transplant. Transplants of skin and other organs have been tried even before 1950s, but the first successful kidney transplant was done in 1954 between identical twins. And this, the donor and the recipient, the donor survived more than 40 years after the donation, and the recipient died 8 years after kidney transplant. And after this first successful transplant, Lots of researches have been conducted to try to have a successful transplant even in non-identical people, and they discovered HLA and HLA antibodies in late 1965. And then there was an introduction of CDC cross-matching, which is tested and can help to detect preformed antibodies, so that recipient can be managed and to reduce the risk of rejection. So advances progressed with the discovery of the immunosuppressant drugs, starting with azathioprine, which improved the graft survival up to 50%, but still the rejection rate was still high. In 1980s, there was a discovery of cyclosporine, which revolutionized the transplant program with a graft survival above 80% when cyclosporine used combined with azathioprine and prednisolone. So currently there are a lot of medications that are used in kidney transplants, and most of them, among them include the other carcinogen inhibitors, including tacrolimus, and which is one of the cornerstone of immunosuppressive therapy in transplant patients. And this, with the new expansion and discoveries, the graft survival is above 90%. Even now, the transplant surgery is more safer with the robotic surgery and the laparoscopic surgery. So what happens when someone gets a kidney transplant or any other organ transplant? There's an immune response if the recipient is not identical with the donor. So the immune response is summarized as a 3-signal model of T-cell activation. So once the organ is transplanted, because at the cell surface, they present the HLA, the human leukocyte antigen. So they are presented to the recipient antigen-presenting cells, which will recognize those antigen or protein as non-self. And if they are recognized as non-self, these antigen-presenting cells will stimulate the receptors at the cell protein cell surface, will stimulate the receptors to trigger a reaction cascade that will lead to cytokine production and T lymphocyte activation. And with this T lymphocyte activation, if the organ is not tolerated, the organism will start to reject the organ donated, or it's same as when in case of infection. So with the T cell proliferation, there's B lymphocyte activation and then formation of antibodies, which initiate the complement activation and complement cascade with inflammation, and end up by having an allograft rejection. So to prevent this, that's why those patients post-transplant, they need long-term immunosuppressive medication to prevent rejection. So what do we do during evaluation? So the evaluation pre-transplant is indicated to all patients with CKD stage 4, 5 who are expected to reach kidney failure. And those patients should be informed first and educated about kidney replacement therapy and mainly kidney transplant. And the main reason is to try to avoid dialysis as much as possible by probably doing preemptive kidney transplant. And as recommended by the KDIGO, this shouldn't consider any socioeconomic status, sex, gender, or identity or race. And the aim of the transplant evaluation is to detect and treat coexisting illness, which may affect perioperative risk and survival after transplant, and evaluate the cause of chronic kidney disease and recurrence risk, assess the immunologic compatibility of the donor to the recipient, and assess the general health and surgical risk of the donor, including screening of conditions that may predict complications from having a single kidney in the future for the donor, and determine if there are diseases that may be transmitted from the donor and the recipient. So the evaluation is adapted to the local guideline. And so we go through this process. It starts with psychosocial evaluation to assess the patient lifestyle and assess if there's psychiatric or psychology condition that may impact the long-term survival of the patient post-transplant, assess if there is any use of substance or if there is a risk of non-adherence post-transplant, and the patient also receive counseling as the donor receive counseling about kidney donation. So the recipient also will receive pre-transplant counseling and education on what is the post-transplant follow-up process. After the psychosocial evaluation, we go through medical and immunology evaluation. So the nephrologist will do history, physical exam, and investigations to know the cause of kidney or chronic kidney disease and assess the risk of recurrence of that disease, because there are diseases that can recur after transplant and again cause the graft failure. So we go through the evaluation, looking for infections. If there's active infection, they should be treated first. Look for colonization or chronic infection that should be to prevent reactivation after transplant. We do virus screening, and we check for vaccination status, and we can also recommend to update the vaccination before the transplant. We do the cancer screening according to the guideline, and then again we assess for any chronic condition that can affect the outcome post-transplant. And we look for CKD-related complications, and then they are to try to control them. And we check for blood group compatibility and HLA typing and cross-matching. And after that, they go through the surgical evaluation to assess the vascular anatomy and the patency, if there is any condition that can compromise the surgery, like obesity or coagulopathy, and the need of simultaneous native nephrectomy or nephrectomy before the kidney transplant. So this is a long list of contraindication to kidney transplant. Basically, any medical condition that can shorten the life expectancy of the recipient candidate to less than 2 years is a contraindication to kidney transplant. If there is a condition that can be managed before the transplant and being controlled, then we go through, we treat first that condition before proceeding to the transplant. For the compensated cirrhosis, the recommendation is to do simultaneous liver and kidney transplant because only kidney transplant will not help in patients with cirrhosis. So regarding the surgery, for leaving donor kidney transplant, the surgery, the nephrectomy and the kidney transplant are done simultaneously. The nephrectomy can be done openly, like open donor nephrectomy, or can do minimally invasive, like laparoscopic nephrectomy or robotic nephrectomy. And the kidney is preserved in cold storage. And so we have to make sure that at least the ischemia time or the time when the organ is out is shortened as much as possible, because this will determine the graft survival. And the transplant is usually done by the procedures. The graft is implanted at the iliac fossa, and the renal vein are anastomosed to the external iliac vein, and the renal artery anastomosed to the external or internal iliac artery, and then the ureter is anastomosed to the cystotomy. There are complications associated with surgery, including infection or vascular complication, which are crucial, like bleeding, renal vein or renal artery thrombosis or renal artery stenosis. And there are other also urologic complications like urinary leak or ureteral obstruction or penephric collection like lymphocele. So to prevent rejection, those patients should be on immunosuppressive therapy. The medication are started before the surgery, before the anastomosis, and then they should be continued for life, at least for the time of graft function. So we start with identifying the immunologic risk of the patient to determine which immunosuppressant to give, especially as induction therapy. And because of this medication have a lot of drug interaction, they have to be looked into, and we have to watch also the drug side effect. So this is a medication that are usually used for induction therapy. We use high-dose corticosteroid. combined with a depleting lymphocyte depleting agent or non-depleting agent like basiliximab. And for the maintenance therapy, we use calcineurin inhibitors of the nucleotide synthesis combined with corticosteroid. For the post-transplant management, immediate post-op, patients should be on these maintenance immunosuppressant drugs. And we usually check for graft function by checking the urine outputs, and also because they usually have polyuria post-kidney transplant, we check for fluid and electrolyte, and then we manage accordingly. We manage other associated comorbidities, and then they need the surgical follow-up and the supportive care. They usually, if everything is okay, they go home within 4 to 5 days, but they need a close follow-up. So in the first 3 months, they receive antibiotic prophylaxis according to the guideline, and because to prevent opportunistic infection, and they have a scheduled follow-up. Here we do in the first 2 weeks, 2 times per week, and then after weekly if the graft function is okay, and then every 2 weeks, and after that we go. They come every month to see the nephrologist, and we are, in that period we are teaching them about the drugs and the adherence to medication. So the long-term follow-up. So they are on lifelong immunosuppressive therapy. So we're looking for those drug-related complications, because like the calcineurin inhibitor and nephrotoxic. So we check regularly the graft function, drug level, and we look for the long-term complications associated with post-transplant. So those post-transplant complications, depending on the age of the graft, early complication includes delayed graft function or hyperacute or early acute rejection. There are surgical complications that usually are early, and electrolyte disturbances and infection, mostly nosocomial infection, but later they can also develop opportunistic infection. And long-term complications include graft-related complications and patient-related complications. The most common cause of death in post-transplant patient is cardiovascular disease. In 40%, 20% is infection, and 10% they may develop malignancy, mostly skin cancer and post-transplant lymphoproliferative disorders and others. And graft-related complications include acute rejection, especially if they have HLA mismatch or prayer sensitization, or if they have suboptimal immunosuppressive medications. So the post-transplant outcome, the survival rate in living donors up to 98% at 1 year, and 90% at 5 years, and around 75% after 10 years. It may go lower to the deceased donor, kidney transplant. The graft can survive more than 20 years, and the common cause of death, as we said, is cardiovascular disease. Sometimes patients may need multiple transplants, especially in pediatric population. The risk of recurrence of primary disease depends on the cause of the kidney disease. If known, unfortunately for our patients, most of them, we don't know the cause of native kidney disease. So the most disease that recur quickly, or like they're certainly to recur, primary oxalosis and hemolytic uremic syndrome and some of the GN. The graph is showing the risk of recurrence in glomerular disease, and the most common is immune crescentic GN, and then IgA nephropathy and FSGS, and mesangial-proliferative glomerular GN. So the survival rate will depend on the source of the graft, and depend also on the recipient and donor age, the comorbid conditions or the cause of the kidney disease, the initial kidney disease, and the degree of immunosuppression. Some medication may, for the reproduction, regarding the production in recipient, usually the fertility and sexual function improve after transplant in 1 to 2/3 of patients. And for this, we recommend them a family planning, especially for female in the first year post-transplant. For the male candidate, some medication may impair testosterone biosynthesis, so they should be educated about that. And when it comes to pregnancy, so we have to plan this to adjust the immunosuppressant medication, because some of the medication like antimetabolite have a side effect on the fetus. So talking about kidney transplant program in Rwanda, so kidney transplant is being done at King Faisal Hospital. So before this program, patients used to go to outside the country to get a transplant. The first transplant was on a Rwandan patient, was done in Italy in 1999. And this patient, the graft function lasted more than 25 years. In 2013, here they tried to initiate kidney transplant. They did 3 surgeries, which were successful, but then later on, patient had different complications that due to logistics, the program couldn't proceed. So, and that time there was only 1 nephrologist and later on 2 nephrologists. So before 2022, more than 120 patients got a kidney transplant abroad and mainly in India, and some of them were with help of the government. And in 2022, the University of Rwanda with the King Faisal Hospital initiated the fellowship program. And after that, in 2023, they started the Living Donor Kidney Transplant Service in partnership with the University of Michigan. So currently we have a renal pathologist that can diagnose kidney disease, and also is helping us. They are helping us in a follow-up post-transplant. There's a national living kidney transplant guideline that is available, and there's a national transplant committee that is in charge of assessing if the transplant program is working perfectly, and just to avoid mostly this correction, as we're saying. And the insurance, the community-based insurance is covering more than 90% of patients that are receiving kidney transplant here. Starting this year, we're doing in-house kidney transplant. So there's 9 hemodialysis centers, almost 500 patients on chronic dialysis, and among them 217 are under evaluation for kidney transplant. Among them, 89% received the kidney transplant within these last 2 years, including one pediatric patient that received the kidney last year. So the outcome of those patients, over 89, 2 had graft dysfunction and they're back on dialysis, and 4, we had mortality, 4 and 3 of them had sepsis. So the plan for the future perspectives, because the immunology lab, we don't have immunology lab, so we have to send for HLA typing and cross-matching in Belgium. So we're planning to have an immunology lab here, and we started to do laparoscopic nephrectomy, and we're planning a kidney transplant registry, and also we're planning to expand the access to the region. And again, because of this limited access to donor, we're thinking on how we can expand the program with deceased or donor transplant or donor exchange, if possible, because also other organ transplant programs are planned. So this is the process, how the patient goes through. So the patient comes from different referral hospital, dialysis center. They received a nurse coordinator, the transplant nurse coordinator, and after all the information and the informed consent form, they go through the evaluation process. After, they are seen by the National Transplant Committee, and then they get the surgery, and they are followed up at King Faisal for 1 year, and they are referred back to the referral hospital. So in summary, this is how we're following those patients. Regarding outcome, we have a good outcome for this patient transplant candidates done here, and even those who received the kidney before this program. So the survival rate was about 95% in the first year, and up to 94% in the second year for those who received the kidney here. And for those who received the kidney transplant abroad, the survival rate was 97% in the first year and goes to 71% after 5 years, and then 61% in 10 years. So this is a summary of my presentation. As a take home, the burden of CKD continues to rise globally, and especially in low-income countries. So the management of chronic kidney disease should focus on prevention, early detection, and delay the progression. And if patient develop kidney failure, we should emphasize on kidney transplant as an optimal treatment and sustainable solution in resource-limited settings. So we need a comprehensive transplant evaluation and the appropriate post-transplant care to achieve favorable patient and graft outcome. Thank you very much. This is the end of my presentation.
Thank you so much, Dr. Gloria, for this great presentation. It was also concise and very clear. We have questions in the chat, but I prefer that we proceed with Professor Martin, and then we will come back for all the questions in the box after. So Professor Martin is a consultant pediatric nephrologist and the former head of Kidney Center of Excellence at Al Jalila Children's Hospital up to 2024. He's a clinical professor of pediatrics at Mohammed bin Rashid of University of Medicine in Dubai. And he's also affiliated member of Division of Nephrology at Montreal Children's Hospital and McGill University Health Center, just to say very little for him. So he has held faculty's position at Wake Forest University and also Montreal Children's Hospital and McGill University. So he's also in Biden. He has a Biden commitment to local and international teaching and outreach. He's very involved in ISN support with Sister Renal Center Initiative, and that's one of that the nephrology teaching. He's also part of the nephrology teaching part of University of Rwanda in postgraduate pediatric residency program. So, Professor Martin, the floor is yours.
Thank you so much for this kind introduction. I have to say thank you also to the organizers allowing me to participate in this nice session. I have a disclaimer. I understand that the audience is varied, and I apologize to those who may find the level not adequately high. So I try to address all of this. So let me share the presentation. Okay, there we go. Share, okay. So now let me do this. Okay. I hope you can see the outline properly.
Yes, it's very clear.
It's something disturbing my field. Oops. No, this disappeared. Your screen sharing, good. How can I bring this slide back to my screen? Full screen, maybe that. No. Let me just stop sharing and share again. Something is not working as I want. Yeah. Share. Okay, make this small. Okay, now. Okay, I don't have any conflict of interest to declare in regards to this presentation. The agenda is mainly to discuss the benefit and role of kidney transplantation for chronic kidney disease. There may be a little bit of overlap with my previous excellent speakers, but then highlight children and with CKD and aspects of pediatric kidney transplantation, as I'm a pediatric nephrologist. In general, as alluded before, chronic kidney disease and end-stage kidney disease are one of the leading global risk factors for death. And understanding chronic kidney disease for those who are not nephrologists is not that simple. So CKD is a condition where kidney function declines gradually over several months or years. Damage is of permanent. Progression to complete kidney failure and end-stage kidney disease may be prevented or delayed, but needs to be diagnosed early. And there definitely is a challenge in many countries in the world, and particularly in sub-Saharan Africa. Generally, worldwide, causes of end-stage kidney disease are diabetes mellitus, and kidney disease and kidney failure happens in about 1/3 of patients with diabetes mellitus. High blood pressure, which puts excessive strain on the blood vessels in the kidney, and genetic conditions. And in adults, the leader here is polycystic kidney disease, but also some forms of focal segmental glomerulosclerosis. Pyelonephritis can lead to chronic kidney disease and end-stage kidney disease. And then we have autoimmune disorders such as systemic lupus erythematosus. So this is in general the picture. Pediatrics looks a little bit different. I will allude to that soon. So when the treatment of, what is the treatment when the kidneys fail? Just for, again, persons who are not in the nephrology field, in most cases, both kidneys are similarly or equally affected. If only one kidney is failing, then we still have 50% of the kidney mass, and that is more than sufficient to maintain normal function of the body. Advanced kidney disease, so usually stage 3B, 4, and 5, generally need treatment. And signs and consequences of failing kidneys are less urine production, for example, edema, body swelling, high blood pressure, cardiovascular disease, and all the negative effects of metabolic waste that is not anymore filtered by the kidneys. So there can be acids, there can be potassium, phosphate, uric acid, and more that are prominent in patients with chronic kidney disease. These patients have anemia and they often develop bone disease. So what is the management? First, medications, as already outlined by the previous speakers, then dialysis, or directly preemptive, or later kidney transplantation. And as already pointed out, kidney transplantation is obviously the preferred form of kidney replacement therapy. And this gives you a graphic overview which systems are involved. You see CKD is a multi-system disorder. We have anemia. We have a high rate of cardiovascular disease. The complication rate is at least 10 times higher than the normal population. We often have malnutrition, and this particularly affects children in their growing years. We have infection immunity problems. We have to consider dosing of drugs, that many of them are excreted by the kidneys. We have acidosis, which then negatively affects various organs, including bones, heart, muscles, and so forth. And we have genuine bone disease, and we call that mineral bone disease in CKD. So when patients require kidney transplant, now we know that dialysis helps manage some of the consequences of kidney failure, but it's a temporary measure. Dialysis does not replace complete kidney function. Dialysis is able to remove fluid and metabolic waste products, but dialysis does not replace hormonal function of the kidneys, such as necessary for healthy bones, for anemia prevention, and so forth. And then the long-term effect of kidney transplant obviously is a better quality of life, no more dialysis, less of the chronic complications of dialysis and chronic kidney disease, and overall better outcome than dialysis. Now, this is something that is not everywhere understood, neither by the population, nor by politicians, nor even by healthcare, health insurance providers, for example. All of them focus, even in our country here and in many other countries, on dialysis as the first measure rather than investing into kidney transplant. And one word is important: kidney transplant, once established, is on the long run even cheaper than dialysis. So what is kidney transplantation? It's a surgery that replaces a damaged kidney with a healthy organ from a living or diseased donor. And it is one of the most successful surgical treatments in modern medicine. And the success rate, as pointed out before, is high when performed under expert care. So as already indicated, it's very important to have pre-transplant evaluation, both to protect the donor and protect the recipient of the kidney. It minimizes harm due to the kidney surgery, for example, anesthesia, surgery itself, recovery, and the patient has to be fit for immunosuppressive medications. For example, if somebody has a chronic infection or recent cancer, then they are usually not eligible for kidney transplant at that moment until this is resolved. The live donor needs to be evaluated, as pointed out by the first speaker, to minimize the risk for the donor and also for the recipient. And disease donor evaluation is important. That's usually not done by the nephrologist, but in the hospital where the diseased person is being cared for, and where thorough assessment has to be done in a very short period of time, because we have only a window of a few days before the kidney then has to be explanted and then transplanted into the recipient. So we have to assess the suitability of the kidney to minimize the recipient, and we have to particularly responsible if the recipient is a child. We do not want to transmit viral diseases, tuberculosis, brucellosis, and many other infections. We don't want to transmit, obviously, a tumor and so forth. And we do want to have a kidney that has a long trajectory of survival. If we give a marginal kidney to a young child and the child loses the kidney within a year or two, then we are actually in bigger trouble than without a kidney. Then there's obviously the donor matching. Again, as already discussed, we need to match the blood group, and we have to match the HLA type, and we have to do the cross match before the transplant to avoid early acute rejection and long-term antibody-mediated rejection. So there is a surgical procedure when the donor kidney is placed into the lower abdomen or in the groin, where the blood vessels and the ureter need to be connected carefully to the respective vessels and the bladder. The surgery may not last very long, usually 3 to 4 hours if there are no complications. And it really depends. In the adult setting, at least in the Western countries, the patient may be admitted for 5, 6, 7 days. Children usually are admitted longer. There are just many more complications to deal with. And during this period of time, there's post-surgical management, complications may be arising. We have to adjust immunosuppressive medications and so forth. And nutrition is a big thing in pediatric recipients because most children have a lag time to resume drinking and taking solid food. Long-term post-transplant care is extremely important. It's usually done either by a nephrologist, a transplant nephrologist, transplant surgeon, or both. And again, pediatrics has a specific role because there are many needs to be fulfilled. And during this time, post-transplant, the graft function has to be monitored, medication level have to be monitored, the blood pressure has to be managed, and we have to assess for various opportunistic viral infections, bacterial infection, and fungal infections that can affect a body who is immunosuppressed. But this is not the end of the journey. So as you see in this overview, if you proceed on the left, CKD 2, 3, 4, and 5, you obtain either dialysis or a kidney transplant, hopefully as soon as possible a kidney transplant. Then we have not completely pristine organs. We have actually to consider all transplanted kidney as chronic kidney disease. You can call that CKD-T for transplant. And then long term, we have various risk factors for this transplant kidney. We have toxicity of immediate medication, particularly calcineurin inhibitors. We have allograft rejection that can compromise the kidney function. We can have disease recurrence. We can have viral infections such as polyomavirus infection. And we see often transplant glomerulopathy that leads to eventually demise of the organ. So essentially, after a certain period of time, and that can be 5 years, 10 years, or hopefully 25 or 30 years, it will eventually lead to graft loss. And we assume in children that they will need 2 or 3 grafts in their lifetime. So what does it mean? We have to be very diligent in the a selection of the donor kidney. We have to be very diligent in the follow-up. And we have to be careful not to hypersensitize children who then are not anymore eligible for or not possible to transplant if they are hypersensitized. And unfortunately, we have a few of those candidates now in our dialysis unit. Oh, sorry. Now, as the saying goes, children are not small adults, and this also applies for kidney disease and transplantation. Children need to grow and develop. That is different from adult recipients. CKD unfortunately leads to poor nutrition, impairs growth and bone due to bone disease. It delays brain maturation and development. Obviously, there's anemia, as in everybody with chronic kidney disease. But in children, we also observe that school attendance is compromised, performance and academic performance is compromised due to frequent illnesses, hospitalization. You cannot concentrate. So there are many factors that strike against the normal development in childhood. So it's becoming very important to provide a kidney transplant as soon as possible, because that will alleviate many of those problems. The other thing is that the spectrum of kidney diseases leading to end-stage kidney disease and transplant is quite different in the younger age than in adult age. If you look here at the trajectory over the years from infancy to adulthood, during the first 10, 20, 25 years, CACUD, so congenital anomaly of kidneys and urinary tract abnormalities, is at the forefront of causes for end-stage kidney disease. Other diseases come more into play in young adulthood and in later adulthood. And in the older adults, we have mainly diabetes mellitus and hypertension and maybe chronic infections and misuse of medications as the main cause of end-stage kidney disease and transplant. So this is just a snapshot of the spectrum we see in Dubai. Again, we have the first two segments in this circle, in this pie chart. They are all inborn kidney diseases, dysplastic kidneys, posterior valve, and we have a high rate of congenital nephrotic syndrome, but that is a peculiarity in the Middle East because there's a lot of consanguineal marriages, and then we have a high rate of this disease, of genetic disease overall. Actually, we are starting now to screen every child with chronic kidney disease and end-stage kidney disease genetically, and we find a genetic mutation that is responsible for this disease in at least 2/3 of the patients. Then there are a few other diagnoses that you all know. Oops. Now, as I mentioned, growth is impaired, and you see in this graph taken from a textbook that often if it's a congenital kidney disease, there's already intrauterine growth retardation. You see poor growth during early infancy and young childhood, and then the growth is even more dismal in puberty and delayed, and you see there is a difference between an average, let's say in that statistic of, let's say 170, 175 centimeter and height, you're ending up with less than 140 centimeter. And this is a big issue for many young people who do not want to be smaller than others. So one remedy is that we use growth hormone deliberately for making at least the growth a bit better. And this is just an example for bad bone disease that is obvious when children are dialyzed for a long time. You see all the rickets and the bone disease and bone disformation. So in our center, we are starting preparing the child and the family for renal replacement therapy, so both for dialysis and for transplant. If we can do preemptive transplant, we obviously prefer that. And we try to prepare when the children reach CKD stage 4, so that we're ready when they are reaching stage 5. And the boundary is not a numeric number, it's the overall functioning of the child. So if the energy is less, nutrition is poor, we have complications, we tend to transplant early, even before they reach a GFR of 15 milliliter per minute per 1.73 meters square. We do preemptive kidney transplantation currently about 1/3 of our patients for PD or hemodialysis before the transplant is ready. And we have careful evaluation for the social, psychological, and economic background. Now, as you see in this slide, it's a multidisciplinary effort and collaborative effort between all the players here: nephrologists, nurses, dietitians, immunologists, endocrinologists, social workers, gastroenterologists, cardiologists, you name it, and obviously urologists, because many of our patients have CACUT, so congenital anomalies of the kidneys and the urinary tract that usually cause a number of complications afterwards. Now, the survival of pediatric kidney transplantation is somewhat similar to those of the adults. Here you see statistic from the NAPRATEC, so the US and Canadian registry. On the top, graft survival, and the bottom, patient survival. And you have two eras. So the lower lines, the black lines, are disease donor. The red ones are the living donors. Living donors fare better, both in terms of patient survival and graft survival. And as you also see, when you go from the solid line to the broken lines, that over the years, the survival of the graft has improved due to better immunosuppression, better knowledge, and better management of various complications. So transplant surgery in children can be challenging, and this is mainly because most of the transplanted kidneys are adult kidneys, parents, other relatives, or disease donors. So we have space requirements. We need a very high blood flow in the adult kidney that is implanted into a pediatric body. It actually goes to that extent that a 3 or 4-year-old child needs 50% of the cardiac output that goes just to perfuse the kidney. And if it's not guaranteed, then we have quick fibrosis of the organ kidney and will lose function right from the get-go. So this is a big challenge that has been mastered initially together with anesthesia, and then afterwards we always have to pay attention to the fluid intake. Also, children have a more active immune system and tend to have more rejections. These are some pictures of where kidneys are transplanted, while the adult recipient receives the kidney is connected to the femoral vessels. In children, we often connect to the aorta and the vena cava, if possible. And sometimes we cannot implant the ureter into the bladder. That may be too small. Then we have to ureterostomy and do some other tricks to enlarge the bladder. Sometimes we have, particularly in children with a long history of dialysis, we have a paucity of blood vessels. So we have often children who have exhausted their vascular access. And then it becomes very dicey to connect the kidney. So our surgeon sometimes uses the hepatic vein, the native renal vein or artery to connect the graft because we don't have any more vessels in the distal part. This is just an example of that, even with the aortic conduit. So why is it so important that we look at the allocation? So we say children first, but why? Living-related transplant is often the first better choice, as we discussed, but children should have high priority in disease donor kidney allocation. And this is something that is implemented now in more and more countries, not always accepted by the general population or by adult physicians, but there are a number of reasons why children should be preferred as organ recipient. We have to avoid detrimental effect of CKD on growing organism, as we discussed before. We have to avoid losing blood vessels. We have to ensure normal growth and development. We have to ensure normal schooling and education. And we have to be mindful that countries, pediatric recipients are about 10 to 15% of all the organ recipients, usually even less than 10%. This makes only a small dent into the overall pool of donated organs. And as we show here in this slide from Quebec, where I worked before, the lower slope is the where kidney were allocated just based on waiting time and matching, and it took for 50% to receive their organ about 2 years. And once we had a primary allocation to children, so one of two matching kidneys goes to a pediatric recipient, the other goes to an adult. Within a short period of time, we had depleted our dialysis population, and we have a 50% transplant rate after a few months, 3 months, 4 months, maximum 6 months. So this is what we really should strive for. And once the backlog of pediatric recipients is finished, then there's equal chance for adults and for pediatrics to receive the graft. So it will not be felt anymore as a loss for the pediatric recipient or the adult recipient. Oops. So the goal is not only to restore the patient's health, but to optimize the quality of life for every transplant patient. This is a picture of our activities in our group. Thank you very much. I'm open for questions. Now let me...
Thank you so much, Dr. Martin, for this great presentation. We almost always focus on adult population, but we are very, very keen to learn about pediatric patients also. So thank you so much for the presentation, and thank you for all the speakers. So I'm going to, I don't know if Dr. Elizabeth is back. I was going to give her one of the questions in the chat. I know she has tried to give some feedback directly, but there's one participant who was asking about any culture or context difference which promotes kidney donation in Canada. Dr. Elizabeth, I don't know if you're back.
I am. I'm back. Thank you for asking. I think it's the same thing that motivates people all around the world. So I think there's, people's motivation to help a family member is very strong. And then I think our most success we find when people reach out to the public is when a child needs a kidney transplant. I think people are the most willing to anonymously come forward or donate when you see, this small helpless child that needs a kidney and is on dialysis. But I think otherwise, the idea of altruism it's a shared culture between all over the world. I think as a human experience, that desire to help other people, I think is also quite universal. But Gloria may also have some insight as somebody who's been in both countries, if there's any differences with our culture in Canada that, may influence why people want to donate.
Well, I don't know if I will have the exact answer, but I think what I've seen in Canada is like people are aware of what is transplant and what is kidney donation and everything. And like I've seen people have providers providing the booklet and all the information early. So people are more informed about what is kidney transplant or any organ transplant in the process than here, because here is just starting and it seemed to be still a taboo for some them. And there's like stigma that if you donate a kidney, you maybe may die or you need medication for life and so on. So maybe that a knowledge or awareness is different in the two countries, but also where people want to donate and they want to help their family members or friends, mostly family members, but also I've seen here people coming asking that they want to donate a kidney. Just doesn't know anyone, but just want to donate a kidney. Unfortunately, we don't have those programs that can connect a donor to a recipient or like having those altruistic donation in our program. But I think the most difference is the awareness and the understanding of where it is about donation. Thank you.
So to add to this, it's very important to have a very clear legislation. because as you can imagine, as we all know, there's a lot of organ trafficking and organ donation or organ transplant tourism that leads to unwanted outcomes. So we all know countries where this is poorly regulated, and then altruistic donors may actually be paid donors under the table. We have to be very careful that this is not being exploited, that donors are not being exploited. So that is one thing. And I think the pendulum changed from not even thinking of altruistic donors to now in few countries where it's well regulated, where altruistic donors become even 50% of or more than the living related donors overall. So when there's no relative available or not suitable for medical reasons, and the niche can be filled by an altruistic donor, and that is all clearly regulated, there's no coercion, there's no financial transaction that is not transparent, then it's a good thing to think of. But not every country is ready for that. And I think once everything is established and the legislation is very clear, then this obviously becomes a very important focus.
Yeah, and I think there's a difference too between sort of anonymous directed donation, so where you don't know the recipient, but you have a very specific recipient in mind. And I think that situation in particular can be the highest risk because that's where that possibility of the recipient contacting you. Versus in Canada, we also have non-directed anonymous donation where you are donating, but without knowing who that recipient is going to be. And I think in that situation where it is true, probably the likelihood of coercion is much lower. And so that's one possibility too of considering the difference between directed anonymous donation and non-directed anonymous donation.
Dr. Elizabeth, do you have other types of living donor program like exchange pairs? Do you?
Yep. So we also run a kidney donor paired exchange program across Canada. So we run our program 3 times a year. We run the algorithm and we match patients that are either an ABO blood type mismatch or are sensitized against their donor through this program. And we just did, I think, our 1000th kidney transplant in Canada through the Living Donor Paired Exchange program. So it is a very successful program. I think probably about 15 to 20% of our kidneys are done through the paired exchange program. But it requires a lot of coordination between sites. And another really important part of the paired exchange program is that everybody agrees to a common set of criteria for acceptance of donors. And so we've actually published our criteria in Canada. It's a publicly available document that you can find as sort of an example of the GFR cutoffs, the glucose cutoffs, the blood pressure, things like that. And the reason we do that is because we don't want chains to collapse when one group brings in sort of a more marginal donor and then another group says, after the paired exchange has already happened, we're not going to accept this donor because they're not good enough quality. So we have a minimum requirement across Canada in order to enter into that program so that chains don't collapse. And I can link our link to that criteria that we use in the chat in case anybody's interested.
Thank you so much. There is also one question for Dr. Gloria about challenges that we have encountered since 2023 that we resume a national program. Maybe you can go briefly. Yeah, I know we have many, but you can try.
Okay, so this maybe you remind me or you complete me when I forget some. So there are a lot of challenges. So the first one is having donors, candidates, because so those patients have to find themselves either a relative or a friend who accept to donate. And sometimes when they go through the psychosocial evaluation, you just find that the donor are not probably ready or they are not suitable for the donation. And then so when you bring one or two, the recipient will have issue of finding others, other donor candidates. That's one. And the other thing is when we do evaluation, we don't do immunology test here. So we have to make sure that the donor that we're having is almost fit, and then we send the immunology lab. So which also this limit the number of candidates, and again, so it delayed the process because sometimes we have to wait for some time to get to send the samples or to get the results, and with all the logistics. So the other thing is because initially, because it was something that is new, the trust of the population was not that good. At least now, because they see the results, they're still to trust and come present themselves for the evaluation. But initially, it was another challenge on having candidates for the surgery. So the other challenge maybe is financial, because those patients are coming from far. And so sometimes they have socioeconomic status, which compromise the process, and they are having complications in between related to dialysis, or the access to dialysis, which is limited, and then they have complications that again delay them to get the transplant. So this also is another challenge. Again, because even if we say that the transplant is not that cost intense as dialysis, but again, it is also cost. It needs enough finances, especially in the first year, in the pre-evaluation, and then the surgery, and then the post, because of course the insurance coverage, thankful to the government that they are covering them to 90%, but also 10% is sometimes a big amount to the patient and their family. And again, there's a lifestyle change that goes with the transplant, especially in the first year, because we're just recommending them safety and enough hygiene and so on. And sometimes also is a big burden to them. And again, when I presented a 1 year post transplant, they have to go back to the referral hospital. As most of those referral hospitals, they don't have suppressive medications and drug level monitoring. So again, patients have to travel to come back to do the test or to get the medicine. And sometimes we have a shortage of medicine. Of course, we don't have a stock out, but we have a shortage, and so it's a big challenge to us, because the access to medicine and further investigations. And again, if someone has serious complications, also this is a challenge. I know it's a long journey, and we're grateful that at least we're doing something, and the outcome is good, but there's still a lot of things that we have to work on. Thank you.
Thank you so much, Dr. I think you went around almost everything. There's also another question for Professor Martin. So children with CKD still get frequent transfusion in Rwanda to manage anemia. Can you comment on this practice?
So if I understand correctly, the question is whether, no, the statement that kidney transplant recipients still get transfused.
Children with CKD and who gets multiple transfusion to correct anemia. So comment on the practice.
The strategy since a decade is to avoid transfusions, obviously, because we do lead to sensitization, and to use erythropoiesis stimulating agents such as darbepoetin, erythropoietin, and avoid that. So unless there is an acute need, we should always be very reluctant to do transfusion, but sometimes we can't avoid it. That definitely brought down the sensitization rate. Now, I don't know whether in Rwanda, for example, erythropoietin, darbepoetin are easily available or whether they're very costly. But in the end of the day, transfusion is more costly than erythropoiesis stimulating agents. So I don't know what the background of the person is who asked.
Since last year in July, we have now coverage by the community-based health insurance covers also chronic hemodialysis, so including also the erythropoietin based product. So it's also covered by 90%, and then they can receive it through dialysis.
Yeah.
So
The other.
Sorry.
Oh, I was just going to say with red blood cell transfusions as well, if leuko-reduced red blood cell transfusions, so where they've removed almost all, like over 99% of the white blood cells, have a much lower sensitizing effect. And so in Canada, we universally started offering leuko-reduced red blood cell transfusions. And since that's taken over, the rate of sensitization from transfusion has dropped significantly. So that might be something as well to work with the blood bank to see if that is a possibility for administering, because if for at least for potential transplant recipients.
That's correct, but we should not forget platelets also have HLA antigens, and there are fragments of platelets always that we cannot filter out. So it's not a zero risk, but it's definitely reduced.
I think
and it's commonly practiced in blood banks to use this method, but it's worthwhile to look into each country and each center where this is actually being done, particularly in district hospitals.
So what I was going to say, it's the same even in adult, even adults are getting transfusion. I think the main problem, or the main problem is like when are we seeing or are realizing that a CKD patient has anemia, because we are just seeing them when they have the compensated anemia, the HB less than 7, and then so we have to act quickly. So if there was way, if like we could, for example, check those CKD-related complications before and start erythropoietin or any other management before they have that severe anemia, this will save them to get transfusion. I think that's the same for children or adults. It's just we have to monitor them before they develop that symptomatic anemia that require transfusion, because the practice is those patients are just coming to district hospital or to the health center because they have those symptoms. And so I think it's a matter of follow-up and to know maybe when exactly to start erythropoiesis. And maybe that can prevent more transfusion as we are doing now.
I think it is all part of the puzzle of early recognition of CKD and awareness. And this is exactly why we're meeting here today and why we have World Kidney Day. But it's a long journey for each country because it's cost intensive and it needs a lot of education and so forth. So what you're saying is absolutely right. And I'm projecting that over the next 10 years, the situation will change in Rwanda and the situation will be much more closer to what we have in, let's say, North America and Canada and other countries. I'm very hopeful.
Professor Martin, just out of curiosity, how the children do tolerate anemia? Because in adult they do tolerate very well, even below 6 sometimes, and we can have some few times to use high dose of erythropoietin and see a rise of hemoglobin.
Yeah, the challenge with children is if they're young and need dialysis, often we have to give blood during the dialysis procedure. We try to avoid it, obviously, but sometimes it's not possible because the circuit is too big and we deplete the blood, particularly if they're already anemic. But again, the earlier you diagnose and are aware, the earlier you can institute erythropoiesis agents and then at least reduce the number of transfusions. There's no way around that, but exactly.
Thank you so much. I don't know if any comments from the speakers. So I think we are going to close by here. So I want to thank you very sincerely to all the speakers for the nice and wonderful presentation. So we have, today is the World Kidney Day, but we have been doing different activities throughout the week with the collaboration of our stakeholders. So the Ministry of Health, the Rwanda Biomedical Center, the King Faisal Hospital, and different referral hospital, and mainly we are doing it with the Rwanda Renal Organization that we are all part of here. So I want to thank all the participants to have attended this wonderful webinar, and it was very, very instructive. So for those ones who wish to have CKD points, so please remember to register so we can track you. Thank you so much, and have a very wonderful evening, and happy Kidney Day to everyone.
Happy World Kidney Day, everybody. Thank you.
Thank you.
for the
Bye-bye.
great opportunity and for the meeting.
Bye.